My name is Oladeinde, and I am a program officer at the National Institute on Minority Health and Health Disparities. And I hope most of you had a chance to watch the video on the Patients Program YouTube channel. So today I'll be presenting very briefly on the NIMHD Research Framework. I'm going to show the framework, and I really want to talk about what this framework means for minority health research and also for patient-centered outcomes research. Before I start, I just want to say this truly feels like a homecoming for me. I was a postdoc in the patients program, and I really had the opportunity of seeing the program evolve over the years, and it's very exciting to come back to do this. So this framework was developed as part of the 2015 NIMHD science visioning process, and it was really intended to be a way to convey NIMHD's philosophy and priorities for minority health and health disparities research. So it was really developed from the socio-ecological model and the National Institute on Aging Research Framework. And when you look at this framework, one of the things that you can see is that at the very top, you have the levels of influence, and here you have the domains of influence over the life course. Another thing that you would see when you look at the framework is that there are 4 levels of influence: the individual, the interpersonal, community, and societal levels of influence. Really, the way the framework was designed, it was really designed to expand your thinking. And when I say your thinking, whether you're a researcher, whether you're a clinician, whether you're a community member, it was really designed to expand your thinking so that, as a researcher, you're not just thinking from the biomedical model, but you're really considering all the other factors that may influence health, and whether it's at the individual, interpersonal, community, or societal level. So when you look at the domains of influence, the domains of influence is looking at the biological, behavioral, physical built environment, sociocultural environment as well. So really, this framework, the intent of it is for it to be used to, like I said, expand your thinking, and also to look at the other factors that influence health. The goal really is to look, and it may sound that I'm repeating myself, but I really want everybody to go away with this take-home message that it is a tool to help you think beyond the individual level, to see that there are factors beyond the individual level and the biological level that influence a person's health and the health outcomes we see. So one of the distinguishing things about this framework is that it does include the healthcare system as a domain of influence. Some of the other models that are out there do not necessarily include the healthcare system as a domain of influence. So with this one, we see it as a strength, right? That when you include the healthcare system as a domain of influence, the reality really is that sometimes the healthcare system may not necessarily always, have a positive influence, and is also one of the structures and the systems that are in place. And so the healthcare system has a way of influencing some of the health outcomes that we see. And if you really want care to be tailored, for it to be patient-centered, it's really necessary to address the barriers to accessing and getting healthcare that may prevent some groups from being able to access healthcare more than others. The other thing that I wanted to highlight here is the life course perspective. So this is very important because we know that one needs to look at the factors that are, and when I say factors and determinants, I'm using them interchangeably. One really needs to look at what factors influence a person's health over the course of their life, not only at the point when they come to the clinic because they are sick, but what are some of the factors when they were children that may be a determinant to what we see now that they're adults, and how does that influence their health outcome? So those are the key things that I really want us to take out of this framework as we look at this framework and as we delve into some of the questions that have been submitted, and some of the questions that hopefully you all will submit.
Janice Tufty has a question. You can go right ahead, Janice. If anyone else wants to ask a question, go and raise your hand or put it in the chat.
Do you
Sure.
also want us, sorry, 1 second, Janice. Do you also want us to address some of the questions that people sent in ahead of time?
Yes,
I didn't
sure.
know the order.
Yeah.
Okay,
That-
so Janice, you go ahead, and then after you go ahead, I can start with some of the questions sent ahead of time.
I appreciate the framework, and I hadn't actually seen it before because it's so important. And you framed it when you mentioned that it's not usually one determinant, positive or negative. It's always in intersectionality between perhaps as biopsychosocial, factors. And so I like the levels of the domains. And I'm just curious, I saw you provided 3 places where it had been utilized, I believe, where you're, in the case studies, which were very different, right? And looking at wellness versus looking at disparities. And I'm just curious, what other opportunities do you think are, where this might be utilized where it hasn't been yet?
All right, Janice. I take it that you watched the video, so you did your homework. So yes, the framework has been used. Those 3 examples, and those 3 examples are on the NIMHD's website. And for one, Manson, the first one that I have in the slides, Sparrow Manson from University of Colorado, one of the things he did was that he adapted the framework to emphasize the determinants that are salient to the American Indians and Alaska Native population. And the reason he did that was because he realized that usually the cultural experiences of that population may, when you use the traditional frameworks, the experience, it may not really capture the cultural experiences and the nuances of those native groups. And so that was why he decided to do that, and he focused on only 2 domains of influence. One of the things I did say in the recording was that, it's not necessary that you need to address every single level of influence or every single domain of influence, because the reality is that based on your research question, it really may not lend itself to you addressing every single one of the determinants. So you just need to know what your research question is and which of the domains and the levels of influence would best suit addressing your research questions. Now, when you talk about intersectionality, I think you made a mention of that. One of the things that, and when people say intersectionality, right, they may refer to different things. So when I talk about intersectionality, one of the things that I mean by intersectionality is that you're looking at the importance of examining all the intersecting positions or statuses that one may hold. And I'll give an example. Say, for example, you have somebody who identifies as African-American and somebody who the same person also identifies as a sexual and gender minority. Now, this person identifies as 2 things, right? As an African-American, they may be female, so they identify as a female, and they also may be a sexual and gender minority, so they also identify as that. So those are 3 different statuses that they identify as. Now, when we are looking from an intersectional lens, right, what happens is that what are some of these intersectional vulnerabilities based on this person's status that may influence the health outcomes that this person experiences? So is it because they are Black? What part of their experience, due to them being Black or due to them being a sexual and gender minority, may be leading to some of the health outcomes that we see in this particular individual? And then when you add the layer of gender on top of it, so this person is female, this hypothetical person I'm using is female, does that also add another layer of complexity, which I'm sure it will add another layer of complexity to it. So when you look through an intersectional lens, we do recognize the importance of examining all of these intersecting statuses and positions, because they all confer different risks, different vulnerabilities, different protective factors. And NIMHD does support, intersectional approaches to research. So I hope that answers your question. If I did not, let me know.
No, I just appreciate it because I'm involved with complex care and social needs research. And so it's so important, and there's so many challenges, and this research is a good framework that can be used at different levels. So yeah, the intersectionality is a term I think is kind of perhaps overused, but it's very important in the context of how you're using those intersections, or what you're going to do at those intersections is important, especially from the community level. Thank you.
You're welcome. So this person said that she works with companies, and I'm assuming these are pharmaceutical companies that develop treatments for rare diseases. And she wants to hear my thoughts about how researchers can adapt the framework as they are planning studies and clinical trials, especially if the studies don't focus on one particular population outside of the rare disease state. So let me state this by first saying that the framework is not intended to be, an end-all be-all. And by that, I mean, you still need to have some kind of conceptual model that you use. What the framework allows you to do is to examine the determinants beyond the individual level, the other determinants that may be contributing to the health disparities that you see. So you have the framework. It helps you to tease apart your research questions. It helps you to determine what angle you want to come from. It helps you to understand what you're doing. But at the same time, you still need a conceptual model, because that conceptual model then helps you to understand how these different factors and determinants are working, what's influencing what, and how do all of those lead to the influence the health outcome. So back to the question that was asked. When you're developing treatment for rare diseases, the way I see it is you, of course, need to engage the people living with the condition to understand their lived experiences, including what symptoms they may experience, how does that impact their day-to-day life, and the outcomes that are important to them as new drug therapies are being developed. And then using all of that knowledge that's gathered to inform the drug development and, of course, the evaluation process. Now, for your question, when you say for studies that don't focus on a particular population outside of rare diseases, the framework can be adapted to look at the effects of the multiple determinants of health. So both the biological and social and all the other factors. And that may provide some insights into people's health behavior and how best to engage the rare disease community in clinical trials, or even when it comes to the planning of these studies. Now, remember when I said that the framework is not intended to be used by itself, you still need a conceptual model. So this may be where you may want to consider combining the framework with something like the patient's program 10-step framework, or some other kind of conceptual model that then puts everything in context. So I think that's one example of how you can use this, especially when it comes to drug development in addressing when it comes to drug development and planning studies and clinical trials.
Dr. Oladeinde, I'm going to put another question in the chat that was from one of the audience, Abdu. So what about the international level, where local communities in some countries do not always agree with the advice and suggestions from international organizations because they want to keep their socio-cultural values, do not perceive positively the involvement of international experts in their country?
I have to read the question again. Thanks, Joe. What about the international level, where local communities in some countries do not always agree with the advice and suggestions from international organizations because they want to keep their sociocultural values and do not perceive positively the involvement of international experts in their country? So I'm a firm believer in always, keeping your cultural values, right? Because everybody has their own cultural beliefs and value system that shapes them. And when I look at the framework again, one of the things I see here, or if you have the framework in front of you, that you may see is that it also takes into account the sociocultural environment. So things like, if you look at I'm saying if you look at, I feel like I should show it. So when you look, so if you look right here at the one of the domains of influence is the sociocultural environment. And then at the individual level, if you want to consider how culture may play a role, how one's cultural identity may play a role, that's right here at the individual level. And then it goes all the way across the different cultural influences. So with that being said, one cannot you still have to address everything within context. Yes, local communities may always push back when it seems as though international organizations are trying to enforce things on them. But that's where engaging the community comes in, because when you engage the community, when you engage the patients, I'm using both interchangeably now, when you engage the community and the patients, what then happens is that they're able to help you to understand the nuanced context and the cultural context of that society and their values, and how that can be used in furthering the research or in furthering the clinical trials. And I'm assuming this person may be from pharma. I like the question. So the question is, who should be engaged to fill out the framework? Should we include community members, government employees, etc.? So the framework is really for everybody. It's not just for researchers. So if you're a researcher and you want to engage the community, what you can do is, it could be, a whiteboarding session where you have your community advisory board or your patient advisory board, whatever you want to call it. They're all in the room, everyone is in the room, and it could be a case where you print out the framework, put it up on a whiteboard, and then ask questions around that research question, ask specific questions around the research topic. It's intended to be used by everyone. So you engage the community when you're, trying to brainstorm and figure out, the factors that may be, or the barriers that may be preventing them from getting the COVID vaccine, for example, and each person, has an input in it. And then as a research team, you come together and start having a discussion around that. So that's just, one example for, of how this could be used.
Which stakeholders should you be engaging other than community members, potentially government, other stakeholders whom you might recommend be included?
Yeah, so like I said, everyone should be included. It's not meant for researchers only. Okay, the framework places genetic factors under the individual category. Many experienced researchers are still studying genetics at the population level, associating genes with racial. So the question is that the framework places genetic factors under the individual category. Many experienced researchers are studying genetics at the population level, associating genes with racial categories. This practice has been debunked by many, but still runs rampant. Could this framework help us put to rest the idea that racial groups are biologically different? So I said, I think where this person is coming from, or maybe coming from, because I cannot read the person's mind, where this person may be coming from is the idea of using race, which we know is a socio-political construct, as a biological construct. I think that may be where this question is coming from. And like I said at the very beginning, the framework is solely to understand what determinants, what factors may be contributing to some of the disparities that we see. So I don't think that the framework can help to put this idea to rest. Definitely more research needs to be conducted on this, and we can see that there's a lot in this space, a lot of work going on in this space right now about race, genetic ancestry, ethnicity, and even with the removing race from clinical algorithms. So there's a lot of work going on in this space. So I don't want to delve too much into that, but I would say that the framework can definitely, I don't think it can help us put the idea to rest. And the framework is even still being, it's still being worked on. Even recently, I think recently being like 2 weeks ago, there was a paper that was published by our director and our deputy director, along with some other co-authors, and they're even thinking they're considering expanding the framework. So that just gives you an idea of, yes, we've had this framework since 2015, but as more people get to use the framework, we're working on the framework improving upon the framework to include all the different components that we may not have necessarily thought about when this framework was developed initially.
Have you seen great examples of how pharmaceutical manufacturers have partnered with payers to address the healthcare system domain?
That's a good question. I haven't really seen many examples of that. I haven't really seen many examples of that. Yeah, but I can look into that because I don't think I've seen many examples of that.
I think this is a really good question because it kind of takes it back to the audience. Has anyone else in this group used this framework or something similar, and what was your experience? If anyone in the audience would like to speak up.
Yeah, like what do you see? Let me add to that. Like what have you seen if you've used the framework, or if you're familiar with the framework? What do you consider to be a limitation, or some of the limitations of the framework, or a strength of the framework?
I'm happy to chime in as someone, Oladeinde, who thinks about this often and enjoys keeping in touch with you over the years. I think that my observations is that oftentimes people who maybe aren't researchers, they tend to focus on a particular row or a particular column that resonates with them the most, right? And so I find that some of my experiences are trying to get people to understand what you were talking about before, that not every box in this framework needs to be addressed everywhere, but that all of these boxes are potentially relevant, and reminding people that that they should consider all of the rows and all of the columns, and then eventually they may not focus on all of them, but not to immediately go to a particular row or column. And not sure if you've had those experiences yourself with people asking you questions about the framework, about tending to focus maybe too exclusively on one area as opposed to understanding the richness of the entire framework.
Did you want me to respond to that? Or
absolutely, okay, I'd like your views and your experiences with that.
Okay, so I think some of the things that we've heard from researchers that are using the framework as far as limitations are concerned is that it's kind of bidirectional. And by that, I mean, and of course, that's because of how it's also presented, right, on paper, on paper. So that's a limitation that we often hear about it being bidirectional, and that it really doesn't, even though you can kind of figure out, what determinants are contributing to what, but there's really no way you can see if, or there's really no way you can propose, or I guess researchers still need to propose the pathways. So you can't really see, like, in a multidimensional way, what is influencing what is dependent on what. And so people still need to propose, like, mechanisms or pathways for how the factors work together, how we may want to test some of these factors. And I think that's one of the things we hear. Another thing is that, even though the temptation usually is that you want to list all the factors, you want to put you want to have every box filled, right? And the temptation is that you want to do that, but then if you do that, but you don't really understand what the direction of influence is, then that kind of defeats the purpose in a way. And it also makes it, even when you think about multi-level research in general, conducting multi-level research and trying to develop, like, multi-level interventions is challenging in and of itself, to conduct and analyze all of that. And that's why I keep on emphasizing that, you don't necessarily need to fill every box. It's just a matter of what is the most relevant to answering your research question. What are the most relevant things to look at? So to summarize what I just said, is that yes, you need to look beyond the individual level factors, but at the same time, you need to also consider and understand the pathways and mechanisms by which these factors are working. So what are the interactive effects of these multiple factors? And then if you want to develop interventions, at what level do you intervene? And this is still a work in progress, obviously. I believe that the field will be advanced when, research is is based on testable conceptual models that includes these pathways and mechanisms by which these multi-level factors may operate to cause some of the health disparities that we see.
Great. Another question I'm going to put in the chat. Do you have advice for people who want to use the framework? How can the user assure that they use the tool correctly?
That is a good question. And I think I made it a point to mention in the video that there's really no right or wrong way to use the framework. And that's why I stress that it's important to realize that when the framework was developed, the intent was that we want researchers, we want people to look beyond individual level factors that may be contributing to health disparities. So there's no right or wrong way. So if I go back to some of the examples I gave of how some researchers have adapted the framework in the past, there was the one researcher that, and this is Sparrow Manson at the University of Colorado, that decided to look at only 2 domains of influence. And those were the domains that was most relevant to the research question he had at the time. There was another researcher that I cited, I think this was from the University of Puerto Rico, and what they did was that they wanted to describe Puerto Rico's living conditions, the historical and sociocultural influences, and how all of those contribute to the adverse outcomes, health outcomes. And what they did for that one was they actually used the entire framework. So for this one, they used the entire framework, and that's still okay. And then there was another researcher that I cited, I think it was Widman and Budwani. And one of the things they did was they combined the NIMHD framework, and then they used the conceptual model, I think from the WHO, I forget which one it was, and they combined the two. And they used both in tandem because they wanted to understand vaccine hesitancy in the Southern United States. And so that was why I said that, even though the framework, when it was developed, it wasn't developed with the intent of, and I think there was a question that was sent ahead of time about, there wasn't really anything said about patient engagement, community engagement. But the truth of the matter is that, there are different models out there, conceptual models that you can pair with the framework. So the framework is for you to understand, for you to frame your research questions, for you to, understand the processes, the underlying processes or determinants that are contributing to what you see. And that's really how it has been used. And of course, if there are more ways that researchers and community members are using it, I'm sure NIMHD will be happy to hear. So the question is, what are the gaps in the framework with respect to patient engagement? Would it be beneficial to gain the perspectives of the participants? And by participants, I guess that's the patients you're talking about. So what are the gaps in the framework?
It's similar to what you just mentioned, so that's why I thought it would be a good question to kind of follow up with. So.
Okay. So yes, so that was, I think that was one of the things I was alluding to, that one of the questions that come was that, when I recorded the video, I didn't really talk too much about patient engagement, community engagement, and all of that. And even though I didn't talk about patient engagement or even community engagement, the bread and butter of NIMHD is about, community engagement, fostering community engagement. So with that being said, give me 1 second, sorry. Lost my screen. Can you still see me and hear me?
Yes.
Okay, I can't find myself, but I'll just go ahead. I'll just keep on talking. So the truth of the matter is that when we think about health disparities, right, one of the things that research has shown over time is that we need to center the margins. And when researchers talk about centering the margins, that's really about, the discourse has to shift from the majority's perspective or the majority groups or the insider perspective to that of the marginalized group. So in this case, I would say the majority's perspective will be the researchers, right? The researchers sitting in their ivory towers. And then the marginalized group or the outsider's perspective sometimes, I would say, will be the patient's perspective or the community's perspective. So we need to center the margins by, shifting from the majority's perspective to that of the marginalized or the outsider's perspective. And this centering is what, of course, can be used to facilitate patient engagement, community engagement, and that whole process, so that way, we're prioritizing the needs and the wants of patients. Now, when you think about what NIMHD does, you think about what I've talked about when it comes to the framework, you realize that patient engagement and partnerships that are developed are really key to addressing health disparities. So when you, this is my belief, that there's really no way that you can conduct true health disparities research if you don't engage patients or if you don't engage community partners in the research process. And true engagement, not just by collecting data about them or from them, but engaging them in every step of the research process as partners. I feel like I'm preaching to the choir here. But where the framework then comes into play is that as you engage community members, as you engage patients as partners in the research process, it allows, the framework comes into play because it allows for you to now look at the entire context, to examine those multiple determinants of health that may be contributing to the outcomes that you see. Now, if you don't do this thorough examination of the multiple determinants, then we run the risk of focusing on the effect of just one determinant. And when you focus on the effect of just one determinant, such as, say, the individual and their behavior, then you're missing the point. And that's why many times interventions that just focus on the individual alone just misses the mark. They're not as effective. So with everything that I said, what I'm trying to say is that we need to address the cumulative effects of the multiple determinants of health. And you do that also by engaging patients, talking to patients, talking to the community to find out firsthand from the community about this. And at that point, then we can scientists can develop well-rounded evidence-based interventions that directly addresses the interactive effects of this multiple determinants that are the underlying drivers of the inequities that we see.
I have another question for you and put it in the chat. Is this framework being recommended or required for those being awarded NIH grants?
That's a good question. It is not required. However, when you look at your funding opportunity announcements, any funding opportunity announcement that's posted, many times they make reference to the NIMHD Research Framework. And I believe that one of the reasons that, the funding opportunity announcements, especially those that come out from NIMHD, makes a reference to the framework is because NIMHD wants to ensure that when researchers are proposing their research projects, they're not just looking at the individual level alone, but they're considering all the different determinants that may be contributing to the disparities or that may be contributing to that research question that you're trying to address. So it's not required. However, almost every funding opportunity announcement I've seen out of NIMHD since the framework was published makes a reference to it.
Great, thank you. Another question here in the chat. How does the NIMHD engage citizens, not researchers or clinicians, in developing research priorities?
That's a good question. I would say that especially during the COVID pandemic, NIMHD has been doing a lot, and not just even NIMHD, even NIH has been doing a lot, especially the Office of, oh my goodness, I need to remember the name of this office. I'm blanking on the name of the office. This is the office that, I'm remembering the name of the former director. I'm sorry, I can't remember the name of the new director, and I don't even remember Mary Bernard's office, and I forget the name of her office. But that office has been doing a lot in conjunction with the institutes and centers at NIH to see how, we can engage citizens, especially community members and community-based organizations in, I won't say maybe in developing research priorities, maybe it's leading there, but it's more about, hearing firsthand from the community. And I remember there were some listening sessions. NIMHD hosted a bunch of listening sessions. Thank you. Oh, so Marie Bernard is the Chief Officer for Scientific Workforce Diversity at NIH. So she's working with the institutes and centers on this. So NIMHD had a series of listening sessions, and the listening sessions were like, more of them were done last year, but it was during the time of COVID. And many of the listening sessions, they invited like community members. So if you're on NIMHD's listserv, you should have seen or received an email saying, if you wanted to be a part of this, you could just sign up for it. They had one for faith-based leaders. They had one for community-based organizations. They had one for researchers. So they had all these different listening sessions. And the whole point was to engage citizens, community members in, coming up with, I wouldn't necessarily say research priorities, but hearing firsthand about what some of the barriers are when it comes to interacting with NIH.
Thank you. Another question I'm gonna put in the chat here. Have you found any challenges with using the framework, and how did you overcome them?
1 second, I just wanted to see the name of the. Okay, so those listening sessions that I was referring to.
Oh, how are you? My name is Gerard Charlot, and I was asking, regardless, about what are some of the gaps specifically with the data collection and distribution.
Oh, sorry, Mr. Charlotte. Yeah, the question that kind of cross questions here.
Okay, no problem.
But yeah, you asked how is data collected and distributed, and I just add some clarification about the particular data that you were talking about.
Oh, okay. The data I was talking about is the data that's collected in research.
Okay.
Okay.
Specific research data. How does it get used for clinical use, medical use, population health? Like what areas or specific segments is that does this framework work best in, so to speak?
Okay. So let me make sure I understand the question, because I thought it was a question in the chat, but it seems like it's a different question.
Yeah, that's fine. Yeah, we can focus on this one, and then we'll get to the other one in just a second.
Okay. So the question is, have you found any challenges with using the framework? And if so, how did you overcome them? I feel like this question is for everyone, not just for me. And the reason why I said I feel like it's for everyone, because depending on the perspective you're coming from, the challenge you find would be different. So from NIMH's perspective, when the framework has been used to, let me see. The framework has been, one of the ways the framework has been used is to see or to think about the types of research that NIMHD funds. And I believe an article, one of the articles I cited in the presentation was an article from 2019, or 2018, or 2019, and it was an article published in the American Journal of Public Health. And the article, the first author is Jennifer Alvidrez. And one of the things that when the framework was developed was to find out, how to identify future opportunities for funding for NIMHD. And the analysis kind of provided this snapshot of NIMHD R01 grants at the time, and to see the what level was being focused on when addressing the different factors. And from that analysis, it helped NIMHD to identify funding opportunities for future research. So that's one way, I guess from a funder's perspective, that the framework has been used. Now, when I say that, and I said that because, if you're a researcher using the framework, and we've definitely heard from the research community about some of the limitations that they've experienced with using the framework, and the biggest one that we hear a lot about is just that, bidirectional, and the bidirectionality, and how the framework is not really showing the multiple ways that the different factors interact. And that was why I talked about the fact that, it needs to be paired with like a conceptual model, for example. Another way that the framework has been used by the research community, and I've not really heard of it as being a limitation, but it was more of within the case of okay, some researchers have used the framework in identifying the research questions they want to focus on, and in also contextualizing and being able to understand the results from maybe their focus group discussions with community members. So those are some examples, off the top of my head that I can think of as far as how the framework has been used. But yeah, the main limitation, like I said, is just that is the bidirectional piece of it, and we need to have it within a conceptual model to be able to understand the pathways for the multiple interactions. But yeah, if anyone in the audience has found any challenges with using the framework, please feel free to chime in.
Maybe we can go back to Gerard. Gerard, do you want to introduce yourself and reframe your question so that Dr. Oladeinde can answer it?
Hi, my name is Gerard Charlot. I'm the CEO and co-founder of Retini, and what we do is we capture the voice, attitudes, and sentiment of people of color with regards to health research. So my question is more because of the differences in data, a lot of missing data, that is in research, specifically when it comes to people of color. How does the NIMHD, did I say it right?
NIMHD, yes.
Yes, okay, NIMHD. Is that one of your objectives to actually get those types of insights?
To get insights
on the data, on the missing data, the data that doesn't exist, that most researchers don't have, because probably there wasn't a framework yet, or NIMHD has not been deployed. Their framework has not been deployed with that particular type of research. Does that create a gap in the organization? And now, based on your overall objectives of what you're trying to meet in the overall organization, is that something that would be helpful?
Okay, so when I'm thinking about, and this may just be me, but when I think about missing data, I'm thinking quantitative data. And I don't know if that's where you're going with that question. But the way the framework lends itself is more qualitatively based.
Right.
And with that, right. So, now that, and I think your question is really asking about before the framework and now that we have the framework. So how do we get insight on missing data? I cannot even speak to before the framework, honestly. But what I can speak to is that now that we have the framework, right, the framework can be used as a tool for organizing your research ideas. And so that's why I went back to the whiteboarding session where you're brainstorming ideas with community members to gather their perspectives. And this is what, this may even start even before like topic solicitation, during the topic solicitation phase, or before those very initial stages where you're, really trying to develop your research questions. So at that point, you can use the tool. And what I believe is that when you use the tool, in addition to any conceptual model you may be using, when you use those in the very beginning stage, right, of the planning process, it makes for better research quality and hopefully not a lot of missing data. but you can use it to organize your research ideas. It can be used to guide data collection, analysis, and interpretation of the qualitative data that's generated. So that way, the framework then provides the space within which meaning can be generated and also attributed to the determinants that are relevant to understanding the health and well-being of these populations that you describe, and which we call the populations that experience health disparities.
No, thank you. Spot on. Thank you.
Dr. Oladeinde, we have about time for one last question before we start to close up. Is there anything else you would like to share with our participants?
Yes, absolutely. I think the main take-home message, and I feel like I'm beginning to sound like a broken record, but the main take-home message is that the framework is not intended to be this comprehensive list or exhaustive list that is like the Bible of minority health disparities research. However, what the framework is that it's supposed to be used to expand your thinking, right? So that you're not just thinking at the individual level, but you are considering all the different factors at the different levels that may be contributing to what you see. So that is, if you took nothing out of everything I've said, that is one thing that I want you to take out of this, that was the reason the framework was developed, and that's the intent of the framework. And also, even though it doesn't say patient engagement or community engagement in the framework, we know, I've already talked about the fact that by virtue of even how the framework was designed, there's no way you can take out the community or the patients, that patient engagement piece of community engagement piece. There's no way you can take that out of whatever you're doing, especially if you are conducting health disparities research. You really need to engage the community. You really need to engage the patients to understand from their perspective, back to the centering margins that I talked about. You bring the voices of the patients, you bring the voices of the community, and you center that, because that helps with, understanding your research question better. Frankly, that helps with even developing your questions and analyzing your data better. And then the beautiful part is that when you end up developing interventions, you have a better chance of the community, the patient population, taking up the interventions that have been developed because you included their voices from the very beginning. So that will be my main take home. And there is really no right or wrong way to use this framework. It's just a matter of what your research question is and your patient population that you're working with.
Thank you so much, Dr. Oladeinde. There are a couple of questions we didn't get to, but I have those questions saved, some other questions that people had, but really want to thank you for taking the time today, and thank everyone for attending. And please do, if you haven't, I'm going to put this link in the chat to attend our other roundtables that are coming up in the next few weeks. You can sign up for for subsequent roundtables, and the recording of this session will be available on our patient's YouTube channel in the next within the week. You can catch up on what was said and go back and look at what we discussed. So again, thank you all for attending, and thank you, Dr. Oladeinde.
Thank you very much for being an engaging audience. And please, if anyone has some questions, follow-up questions, please reach out to me. You know how, if you search for me on the NIMHD website, you will find me. So please don't hesitate to reach out.